let's talk about it in the context of the CDK4/6 inhibitors, like for examples, you know. So the first thing we got to do is, you know, identify the right patient, you know, for the CDK4/6 inhibitors. That's pretty easy to do these days because we're going to use them first-line metastatic breast cancer. If someone has recurred on an aromatase inhibitor, for example, we're going to use fulvestrant and one of the CDK4/6 inhibitors. If they are recurring not on endocrine therapy, for example, we will generally use an aromatase inhibitor with one of the CDK4/6 inhibitors. So that's the easy part. We got to choose, you know, among them for patients, you know, and we have 3 excellent options. And as you said, the efficacy is by and large very similar, you know, in terms of the improvement in progression-free survival. So then we kind of drill down to some patient-specific issues. And some of it's medical, and some of it is potentially even financial, you know, for example, where, you know, the amount of copay can really matter to individual patients, and you really have to strive to get that down as low as you possibly can, you know, for patients. So, you know, for example, palbociclib is a very well-tolerated agent. We just have to watch out for the myelosuppression. Sure. So obviously someone whose marrow is pretty sensitive, et cetera, you know, that can be a little challenging. It's a minority of patients, but, you know, that's an example. Now with ribociclib, you know, for example, the issue there is that sometimes the economics of it can be a little bit better for the patient and therefore for the overall cost to the system, you know, because like when you dose reduce, you know, from 600 to 400 because of usually myelosuppression, the patient pays less of a copay because the cost is less, you know, for that. Right. And so how do you think about that? You know, in the medically integrated setting, you're looking at the patient's insurance and, you know, what their copay options are, Medicare, you know, copay cards, et cetera. Do you think that that can be a benefit to some patients?
It certainly can be, and I think that's one of several elements that a medically integrated pharmacy team looks at and tries to work with the medically integrated team, such as the prescriber, such as yourself, to provide feedback when appropriate to say, you know, this patient you know, has a comorbidity. Maybe the pharmacist picked up or the oral oncology nurse navigator saw in the electronic medical records. Or maybe there's a patient that we know has a history of poor adherence, so they're not real compliant, right? And so we may say maybe a compound that has a less than everyday type of dosing scheme may not be ideal. It might be manageable, but it might need a little bit more hand-holding. It still might be the option of choice, but because the 3 compounds that we have that are sort of on the shelf ready to be dispensed, there's nuances with each of them. Some are once-a-day dosing, another one is twice-a-day dosing. So I think we have to take a look at that too. And again, I think that onus resides with the oral oncology nurse navigator, the pharmacist, again, part of that medically integrated team.
Yes. With ribociclib, too, we have to get the EKG, 3 EKGs, you know, which, you know, now the practices have EKG machines there, and there's setups to be able to get a rapid read, you know, from the cardiologist, you know, et cetera. So that actually is, you know, quite reasonable. You just have to be sure that there aren't drug-drug interactions, you know, for example, or history, you know, of you know, cardiac conduction, you know, issues, et cetera. But, you know, with the abemaciclib, it's, of course, daily dosing. Right. You don't take the week off. It's not the 21 days on, 7 days off the way it is with the palbociclib and ribociclib. But it is BID dosing. So what do you think about that in terms of the, you know, the adherence issues? Sometimes I find it might be a little easier just to take it every day, possibly for some patients, depending on if they've got multiple medicines going on and they're taking everything else every day, you know, for example. What do you think about that?
I think it is a consideration for sure. But again, is it offset by the fact that it's everyday dosing? So you don't have to count 21 days and then 7 days off. So it's a balance. And I think this is one of the quality standards within the ANCODA framework that is talking about how frequently are we getting back to the patient. Now, certainly, the provider, the prescriber, is seeing the patient for certain biomarkers or seeing how well the patient is tolerating it. But it's an incumbent by the medically integrated pharmacy team to also check back with the patient on certain elements that they need to follow up on, like side effect or some of the side effects that we talked about, right? Some of the diarrhea that is prevalent with one over another, or the neutropenia, or dosing. So if a patient is prescribed a compound that has twice-a-day dosing, then that's an element that the oral oncology nurse navigator or the pharmacist should be checking up with the patient. Ask them how many tablets or capsules they have left, right? And when did they start? And document that in the EMR so you know what the answer should be, and if there's any discrepancy, following up with them on why it may be different.
Yeah.
And then developing a course of therapy to help them better understand the importance of adherence.